gross domestic product. So Kenya has recently moved from a low-income country to a lower middle-income country. And okay, that's a good status. I think the economy indicates that the GDP, more money is being produced and all that. But in terms of healthcare financing, what usually happens, WHO and the donors, mostly they support countries that are in the low-income level bracket. So as a result of Kenya moving from a low-income country to a lower middle-income status, it means that some of the programs that were being supported, because the country has, the GDP has increased and all that, they're going to gradually cut off support to programs like those in malaria, TB. So it means that we have to buckle up and ensure that we strengthen our health system. And Grace, you cannot take it away with your advocate of health financing.
Thank you. Good morning. My name is Grace Pendo. I'm a public policy researcher, a sexual and reproductive health enthusiast, and a human rights activist. Profession-wise, I work at PCP, Customer Experience Division. And today I have a very short presentation to take about 5 to 10 minutes on health financing. Health financing is a very wide topic, but I just mind on the key population. So health financing basically is the function of a health system concerned with the mobilization, accumulation, and allocation of the health needs of people individually and collectively in the health system. So mobilization of funds, mobilization through maybe revenues, taxes, accumulation, like pooling, the government and the state pool funds together for one purpose. That's what they usually do every budget year. And so, why did I pick key population? Key population are mostly the most affected groups when it comes to HIV, TB, and malaria. The key population is affected 10 to 20 times more likely. Also, I left my abstract mostly on HIV, HIV prevalence in Kenya. I did not go to borders, but basically in Kenya. So, who are the key population? These are the groups that are affected 10 to 20 times more by HIV, TB, and malaria compared to the rest of the population. They include sex workers, men who are sex with men, people who inject drugs, people in prison, and the transgender. Why is it important for them to be considered? Because right to health is for everybody. It's in the Article 43 of the Kenyan Constitution. So, as I said, globally, the population, the key population, are usually proportionately affected by HIV due to discrimination, risk behavior, marginalization, stigma, and violence. Risk behaviors, as example, sex without protection, injection, sharing injection needles. We say people who inject drugs are also under the key population. Marginalization, because they are vulnerable because of our culture. We tend to discriminate certain groups. For example, I hope you know the people are talking about your conversion to this group. the key population. Am I communicating?
Yes.
Okay. I don't want to be speaking to myself. Also, the stigma when it comes to access and administering of services to this group, and also the first violence. Okay? So what are some of the barriers that the key population face? One, okay, most of these barriers are because of our culture. We tend to the government, or maybe let's say people in general, tend to be confined to a certain way of life, accommodating different cultures or different ways is difficult. So you find that when it comes to access to services of HIV, it becomes very difficult for them, or maybe they will confine themselves to places that they can't access the services because they know they will be received harshly by the society, or the government may not be very receiving to their needs. And then there's policymakers try to prioritize their health needs because of the existing belief that the way of life is unconventional. That's just what I've talked about. Then there's criminalization of repeat. For example, people who inject drugs, sex workers. Most of them, the activities, they will be criminalized. So they will fear to go and get services, and therefore they end up spreading HIV. Then there's lack of legal provision to cater for the essential package that is favorable for KPs, and the universal health. The NHIM essential package, I don't think it covers most of the needs of the key population. For example, there may not be inclusion of maybe, let's say, finger condoms. You can't find it everywhere, like the other type of condom, and many other things that I want to mention today. And so you find that those who are not able to cater for their health, they are not able to access these services under the NHIF or any other. Yeah. Then there's the medical skills and knowledge about the health needs of the key population. The health providers may not be very aware of the needs of the key population. So we find that if someone goes to a health center or a hospital, they may tell them we don't do that here, or we don't give such kind of services to people. You know what they say. For example, mostly it happens to ages. For sex workers, it happens to those that are aged between 30 and 25, where you find the adolescents are not able to get such kind of services. Maybe they will backbite them, they will talk behind their back and say, these are children. So you find that even their, what is it called? The confidentiality of a patient is not there for them. So they may fear going there because of such kind of stigmatization or such kind of behaviors from the health providers. And so I think the government should work into capacity building for the health providers, and not those just who are in the VCT. You know, you go to VCT and it's just counseling and and then you test them. And the rest of the health providers do not have these services. We have other diseases like STIs, HPV. It's not just about testing at the UHC. Then we have lack of provision for sensitization. I've talked about that. Then there's lack of confidentiality. So some of the solutions are like earmarking pooled funds. This is basically, you know what earmarking is? Like when you have a cow, and then you say you're putting something, a plastic there, or you cut it here, so that you identify it as your own. So earmarking is accumulating funds from specific sources and assigning the funds to entirely beyond the general needs of the key population. This way, we will deal with the problem of accountability and lack of priority. So let's say you say a certain kind of revenue goes specifically to deal with the needs of the key population. That's earmarking. Then recognizing the needs of the key population, this can be done through capacity building and sensitization. It will aid in developing structures for training their supply. The essential package, as I had said earlier, is still insufficient. It needs to be upgraded in order to meet all the needs for the key population. For example, I've included the lubricants, harm reduction intervention strategy, HIV treatment care, and sexual reproductive health intervention. There's also a concept of social contracting. This is where the government funds flow directly to CSOs to implement specific activities. So if the government decides to work with CSOs where they directly send a certain kind of fund to CSOs so that they implement that kind of activities, it will be very important. Why should the government choose CSOs for this? Is because CSOs mostly understand the needs of key population and they find the best solution. The government so far has tried the National AIDS Control Council and the NASCO. They have been very instrumental in reduction of HIV, but so far the key population needs have not been met. PEPFAR and Global Fund have been very helpful in capacity building, sensitization, and providing for the needs of the key population, but we are not yet at a place where we can say we have achieved our goals. So, yeah, for me, that's it. I think if the government and the CSOs work together, it will be very easy to reduce HIV prevalence in Kenya and even in Africa. Thank you.
Let's give a round of applause to Grace.